Imagine finding a golden ticket that just completely cures your absolute worst daily symptoms.
Right, like the severe exhaustion or those really debilitating hot flushes.
Exactly. Or, the brain fog that makes it hard to remember your own address. Now, imagine taking that ticket to your doctor only to watch them look at your chart, shake their head, and just tear it up.
Yeah, it's a profound frustration for so many people.
It really is. Because for hundreds of thousands of people, hormone replacement therapy, HRT, isn't this universal cure-all that the media sometimes makes it out to be. For them, it's an absolute biological red light.
And we are really drawn to that narrative of a single universal medical fix, aren't we? But, well, biology rarely cooperates with universal narratives.
So true.
For a lot of people, HRT restores their quality of life entirely. But for a very specific subset, introducing supplemental hormones directly clashes with their underlying physiology.
Okay, let's unpack this. Welcome to today's deep dive. We are looking directly at you, the listener, and asking a highly specific but incredibly vital question. Who is actually not a suitable candidate for HRT due to medical contraindications?
Right, and if you happen to be in that group, what on earth are your options?
Exactly. So we are synthesizing a massive stack of official medical guidance today. I mean, we're pulling from the latest National Institute for Health and Care Excellence NICE guidelines.
As well as the British Menopause Society.
Yeah, the BMS, the Royal College of Obstetricians and Gynecologists, NHS data, and even the newest clinical trials on non-hormonal alternatives like fezolinetant. Our mission today is to figure out where the hard boundaries of menopause care actually lie.
And understanding those boundaries is pretty much the cornerstone of personalized medicine. It's never about closing doors or like gatekeeping relief.
Right.
It is entirely about identifying the exact mechanisms of a patient's body
Yeah.
and finding a pathway that doesn't inadvertently cause harm.
So let's start with those absolute non-negotiables, like the medical deal breakers where systemic hormone therapy is just completely off the table.
Hard stops.
Yeah. The sources point immediately to cancer, specifically current, past, or even suspected breast cancer. And along with that, other estrogen-sensitive cancers, like endometrial cancer. Why is that such a definitive boundary?
Well, to understand that, we really have to look at what estrogen actually does at a cellular level. So estrogen is fundamentally a proliferative hormone.
Meaning it causes things to grow.
Exactly. Its main job is to signal certain tissues to grow and divide. So in a normal, healthy reproductive cycle, that growth signal thickens the uterine lining. But if a patient has a hormone receptor-positive cancer, those cancer cells are actually using estrogen as their primary fuel source.
Wow, okay, so it's like adding fuel to a very specific type of fire. If a cancer is hormone receptor positive, feeding it estrogen is literally exactly what you don't want to do.
That's a perfect analogy. Adding systemic HRT in that scenario is literally providing a growth signal to malignant cells.
So you're feeding the exact mechanism you were trying to starve. That makes complete mechanical sense. And I imagine that's like the exact same logic behind another deal breaker I saw in the NHS guidelines, which was undiagnosed vaginal bleeding and untreated endometrial hyperplasia.
It is precisely the same logic.
Yeah.
Endometrial hyperplasia is an abnormal thickening of the womb lining.
Okay.
So if a patient is experiencing unexplained bleeding or thickening, the medical community's stance is pretty much that you never add a potent growth hormone to a mystery.
Right. You need to know what you're dealing with first.
Exactly. You have to diagnose and treat the underlying cellular issue before you even consider introducing a proliferative hormone into the mix.
That makes total sense. Now, beyond the cellular growth stuff, the guidelines draw this really massive line in the sand regarding the cardiovascular system.
Yes, they do.
And the language in the sources gets pretty dense here. They mention, quote, active or recent arterial thromboembolic disease and previous idiopathic venous thromboembolism. Let's translate that for everyone. Arterial thromboembolic disease essentially means a blockage in an artery, right? Like having a heart attack or severe angina.
That is the perfect translation. Arteries are the vessels carrying oxygen-rich blood away from the heart. So if someone has active or recent blockages there, their cardiovascular system is already highly compromised. It's unstable.
Okay, got it. And what about the other one? Venous thromboembolism, or VTE.
Right. VTE refers to blood clots in the deep veins, which is usually in the legs, or clots that have broken off and traveled to the lungs.
Which is a pulmonary embolism, right?
Exactly.
And the key word in the guidance there is idiopathic, meaning the clot just happened completely out of the blue.
The distinction is critical here.
Yeah.
If a patient gets a blood clot because they say just had major orthopedic surgery.
Like a knee replacement or something?
Right. And they were immobilized in bed for 3 weeks. That is a provoked clot. There is a very clear temporary external cause.
Oh, I see.
But an idiopathic clot means the body's own coagulation system just malfunctioned. It formed a dangerous clot without any obvious external trigger.
Wow. Okay, so their baseline is already risky.
Yes. If a patient's baseline biology has a tendency to spontaneously clot, introducing systemic HRT is considered far too dangerous. Unless, of course, they are already actively managed on anticoagulant blood thinners.
Which would counteract the risk.
Got it.
Now, the sources also flag a few very specific organ-related deal breakers. Active liver disease with abnormal liver function tests is one of them. And then there's a mention of a very rare inherited condition called porphyria cutanea tarda, which I actually had to look up.
Porphyria cutanea tarda is a fascinating, albeit really difficult condition.
Yeah.
It's essentially a disorder involving blood pigment metabolism.
Okay.
The patient's body basically struggles to process hemin, which is a key component of hemoglobin. And for reasons that are actually still being studied, estrogen acts as a massive catalyst for this specific enzyme malfunction.
Right, really? It just supercharges the malfunction.
Yeah, it leads to a toxic buildup in the liver, and it causes severe skin blistering when the person is exposed to sunlight. It's very severe.
Oh, wow. So obviously estrogen is a hard no there.
Absolutely. And as for general active liver disease, well, the liver is the body's primary chemical processing plant. It metabolizes all supplemental hormones. So if the liver's actively failing or highly inflamed, it simply cannot safely process systemic HRT.
Right. Okay, so those are the hard biological boundaries, the red lights. But as I read further into the NICE's and British Menopause Society guidelines, I hit what looks like a massive confusing gray area.
The caution category.
Yeah. Conditions that don't trigger an automatic no, but require extreme caution. The list includes things like high blood pressure, diabetes, migraines with aura, epilepsy, asthma, lupus, dementia, and even a high risk of gallbladder disease. Why are these lumped into a caution category instead of being a hard stop?
Well, these conditions represent really complex underlying systemic issues that HRT could potentially aggravate, but it depends heavily on the severity.
Give me an example.
Take lupus, for example. It's an autoimmune disease that inherently carries a higher baseline risk for systemic inflammation and cardiovascular issues, including blood clots.
Okay.
Or take migraines with aura. The aura, the visual disturbances or tingling someone feels right before the headache hits, that indicates temporary changes in the blood vessels of the brain.
Right, the constriction.
Exactly. And that carries a slight baseline increase in stroke risk.
And diabetes impacts the integrity of blood vessels over time, too. I mean, it wears them down.
That's exactly the connection to make. Because these patients already have a compromised vascular or metabolic baseline, adding a medication that influences blood flow or clotting factors requires a specialist. You have to carefully weigh the severity of their menopausal symptoms against their individual disease state.
But this is where the guidelines pull what feels like a massive medical plot twist. And I love this part. It turns out how you take the hormone completely rewrites the rule book for these gray area conditions.
Yes. The route of administration dictates the risk. It is arguably the single most important nuance in modern HRT prescribing.
Seriously?
Oh, absolutely. And unfortunately, it's one that is frequently misunderstood by both patients and even some general practitioners.
Wait, here's where it gets really interesting, and I want to make sure I'm grasping this for the listener. Are you saying that someone who was flat out denied HRT because, say, their BMI is over 30, or because they have a higher risk of a blood clot, might actually be perfectly medically clear to use a different type of HRT?
Yes. The data overwhelmingly supports that conclusion. Many people mistakenly write off HRT entirely, and they spend years suffering, when the medical reality is that only oral HRT was contraindicated for them.
Wow.
A transdermal patch or a gel or a spray might actually be entirely safe.
How does that mechanically work, though? Why does swallowing an HRT pill create a blood clot risk, but rubbing an HRT gel on your arm just doesn't? I mean, it's the same hormone, isn't it?
It is the same hormone, but it takes a completely different journey through the body. It comes down to a physiological process called first-pass liver metabolism.
Okay, break that down for me.
When you swallow an oral estrogen tablet, it goes into your digestive tract, right? It gets absorbed, and it gets sent directly to the liver via the portal vein.
Okay.
So the liver gets hit with this massive concentrated dose of estrogen all at once.
Ah, okay. So it's like dumping a whole truckload of inventory at a factory door all at the exact same time. The factory just goes into overdrive to process it.
Exactly. And that overdrive is the problem. That sudden influx of oral estrogen triggers the liver to produce certain proteins, heavily altering the balance of the blood's clotting system.
Oh, so it actually makes the blood thicker in a way.
It increases the production of coagulation factors, yes. Studies show that oral HRT increases the baseline risk of a venous thromboembolism 2 to 4 times. That is exactly why it's heavily restricted for people with obesity or a history of clots.
But the gel or the patch, they completely avoid that factory door.
Entirely. Transdermal estrogen is absorbed through the skin, directly into the capillary beds, and slowly enters the systemic circulation. It completely bypasses that initial first-pass liver dump.
That is wild.
Yeah. Laboratory studies looking at thrombin generation, which is a key marker of how easily blood coagulates, they show that transdermal HRT has a completely neutral effect.
Wow, neutral.
Right. It does not force the liver to churn out clotting factors, meaning it does not increase the baseline risk of blood clots or stroke above the patient's normal background risk.
Just changing the delivery method safely opens a door that seemed permanently locked.
Yeah.
That's incredible. And looking at the sources, this nuance of precision prescribing extends to the type of progesterone used too, right?
It does. Progesterone is mandatory for anyone with a uterus taking estrogen because you have to prevent that endometrial thickening we discussed earlier.
Right, the cellular growth issue.
Exactly. Now, older synthetic progestins do carry slightly higher risks for metabolic side effects, and they show slight increases in breast cancer risk over long-term use. But the newer guidelines really emphasize using microdosed progesterone or dydrogesterone.
Because they're safer.
Much safer. These newer options have a vastly improved metabolic profile, and they just don't interact with the body's androgenic receptors in the same inflammatory way.
It really highlights how much the science has evolved from just a one-size-fits-all pill. But I do want to come back to the most prominent boundary we discussed, which is breast cancer. The guidance in the sources here is incredibly nuanced, and honestly, the demographic is massive.
It is. We are talking about hundreds of thousands of breast cancer survivors in the UK alone.
Yeah, and they're often thrust into sudden, really severe menopause by the very treatments that are saving their lives.
And the survivorship data there is quite sobering. Clinical trials, specifically the Scandinavian Habits and Liberate trials, they attempted to see if systemic HRT could be used safely for breast cancer survivors who were suffering from severe menopausal symptoms.
And what happened?
Both trials had to be halted early.
Oh, wow. Stopped completely.
Yes, due to a clinically and statistically significant increased risk of breast cancer recurrence in the groups receiving the systemic HRT.
And our sources note that this applies even if the original breast cancer was estrogen receptor negative. Systemic HRT is still considered just an unacceptable risk across the board for survivorship.
The clinical consensus is extremely firm on that. Systemic hormone therapy, meaning hormones circulating through the entire bloodstream, is a strict contraindication for anyone with a history of breast cancer.
But just like the transdermal loophole we found with the blood clots, the sources reveal another crucial exception here regarding the scope of the treatment.
They do. The distinction between systemic treatment and local treatment changes the entire conversation. Systemic HRT is a hard boundary, but vaginal estrogen is often an entirely different category of risk.
Right, because this targets a specific condition called genitourinary syndrome of menopause, or GSM. We're talking about severe vaginal dryness, tearing, pain during intimacy, urinary urgency, and chronic UTIs. I mean, these aren't just minor inconveniences.
No, they can completely devastate a person's quality of life.
Okay, let me test an analogy here to make sure I understand the mechanism. So, systemic HRT is like putting a chemical dye into the main water supply of a house. It flows out of every tap into every single room. But vaginal estrogen is more like using a spot cleaner on a single rug stain. The rest of the house is completely unexposed. Does that track?
That analogy perfectly captures the pharmacokinetics, yes. Low-dose vaginal estrogen preparations, whether they're creams or pessaries or rings, they're designed purely for local tissue absorption.
Okay.
They act directly on the cells of the vagina, the bladder, and the urethra to restore tissue thickness and a healthy pH. And clinical data shows that these local ultra-low-dose treatments have minimal to zero systemic absorption.
Meaning they don't get into the main water supply.
Exactly. They do not significantly raise the estrogen levels in the general bloodstream.
Which means they aren't circulating back to the breast tissue to fuel any dormant cancer cells.
The risk of that happening is considered incredibly low. And this really brings up a profound issue of patient advocacy, I think.
How so?
Well, being contraindicated for systemic HRT shouldn't be a life sentence of suffering with severe urogenital atrophy. Local treatments exist precisely to support these vulnerable populations.
That's such an important point. However, the sources are very clear that breast cancer survivors still need their oncology team to sign off on this, because it depends really heavily on what cancer medications they are currently taking. Like, the guidelines treat a drug called tamoxifen very differently than drugs called aromatase inhibitors. Why the split?
It comes down to the opposing mechanisms of how those two drugs fight the cancer.
Yeah.
So tamoxifen is an estrogen receptor blocker. Think of it as putting glue inside a lock.
Okay, I like that.
Even if there is some estrogen floating around in the body, it cannot bind to the breast tissue because the tamoxifen has blocked the receptor. Because of this safeguard, oncologists are often quite comfortable prescribing local vaginal estrogen for tamoxifen patients, especially if non-hormonal lubricants have failed.
Got it. The glue protects the lock.
Yeah.
And aromatase inhibitors.
Aromatase inhibitors take a completely different approach. They don't block the locks, they shut down the factory making the keys.
Oh, what?
Yeah, these drugs work by completely eliminating the body's ability to produce its own estrogen. The goal is absolute estrogen starvation.
So if you introduce any exogenous estrogen, even a local vaginal cream, you are handing the body new keys.
Exactly. It fundamentally undermines the drug's core mechanism. Therefore, non-hormonal vaginal moisturizers are the strict first-line treatment for patients on aromatase inhibitors. If local estrogen becomes absolutely critical for their quality of life, the oncology team will usually switch the patient off the aromatase inhibitor and onto tamoxifen before they prescribe the topical estrogen.
The level of chemical strategy there is just fascinating. But let's look at the toughest scenario. Let's say a listener has a true systemic contraindication. They can't use transdermal patches because of a breast cancer history. Their vasomotor symptoms, like the severe hot flushes and the night sweats, are just unbearable. And obviously, local estrogen doesn't fix a hot flush.
No, it doesn't.
Historically, the options for these patients felt like a total medical afterthought.
For decades, it was an afterthought. The dominant conversation in the medical community was always focused on optimizing HRT, which inadvertently marginalized anyone who physically couldn't take it. Clinicians just had to rely on off-label prescribing.
Like what? What were they using?
They would offer antidepressants like SSRIs or SNRIs or even old blood pressure medications like clonidine, basically just hoping the side effects of those drugs might suppress the hot flushes.
But the latest NICE guidelines in our sources are very explicit here. Those older off-label alternatives should not be used as routine first-line treatments for vasomotor symptoms alone. I mean, they acknowledge that cognitive behavioral therapy, CBT, is excellent for managing the psychological impact and the sleep disruption of flushes. But from a strictly pharmacological standpoint, the medical community was just lacking a targeted tool.
They were. But that gap in care is finally closing. The newest breakthrough approved by NICE is a medication called Fezolinetant, which is marketed under the brand name Veozah.
Right, Veozah.
It represents a true paradigm shift in this space because it is entirely non-hormonal yet highly targeted to the symptoms. It doesn't attempt to replace declining estrogen at all.
Okay, I want to try another analogy here because the mechanism of this drug is honestly brilliant. Without estrogen, why does the body suddenly think it is overheating? Is the brain's hypothalamus essentially acting like a broken thermostat in a house?
That's a great way to look at it.
Like the room is a perfectly comfortable 70 degrees, but the thermostat glitches, assumes the house is freezing, and wildly blasts the furnace.
Anatomically, that is exactly what is occurring. The body's temperature control center is located in the hypothalamus, and it's managed by a specific cluster of nerves known as KNDI neurons.
KND neurons?
Yes. In a reproductive age person, estrogen is constantly interacting with these KNDI neurons, effectively keeping them calm and regulated. But when estrogen levels plummet during menopause, that calming influence just disappears.
And the neurons essentially panic.
They do. They become hyperactive and misfire. The brain misinterprets normal, tiny fluctuations in core body temperature as a dangerous overheating event.
So it tries to cool you down.
Exactly. To cool the body down rapidly, the brain triggers massive vasodilation, which is that sudden rush of blood to the skin. And that comes along with a rapid heartbeat and profuse sweating. That is the physiological anatomy of a hot flush.
So if Veozah isn't giving the brain estrogen to calm the neurons down, what is it doing? How does it fix the thermostat?
Fezolinetant is classified as a neurokinin-3, or NK3, receptor antagonist. It physically binds to the NK3 receptors on those erratic KNDI neurons, effectively blocking the distress signals.
Oh, wow. So it just mutes the alarm.
Precisely. It silences the false alarm at the source, stabilizing the brain's temperature dial without introducing a single molecule of hormone into the patient's bloodstream.
That is incredible. And the clinical trial data in our sources shows participants experiencing really significant drops in the frequency and severity of their daily flushes, which obviously translates to finally getting a full night's sleep without waking up drenched in sweat.
It's life-changing for many.
But, keeping with the theme of our deep dive today, does Veoza have its own set of biological boundaries? Who can't take it?
It does.
Oh.
It is a powerful neurological medication, so it requires specific clinical oversight. The primary boundary involves the liver. Clinical guidance mandates monitoring liver function before initiating the treatment, and then periodically during the first few months.
Why is that?
Well, a small percentage of trial participants experience temporary asymptomatic elevations in their liver enzymes. Consequently, it's currently contraindicated for anyone with severe liver disease.
Okay, got it. And what about the breast cancer survivors who desperately need an alternative to HRT? Can they use Veoza?
The current guidance there is cautious. Fezolinetant is not yet routinely recommended for patients with active breast cancer or those currently undergoing active oncology treatments.
Oh, okay.
However, for those who have a past history of breast cancer and have completed their treatments, they can undergo a specialist risk assessment to potentially access it.
So the door isn't closed?
No, not at all. The hesitation isn't necessarily proof that the drug is dangerous for them. It's simply that the specific long-term clinical trial data for these highly specific survivor cohorts is still pending publication. Medicine moves carefully.
Which makes sense. I found a quote in the sources from Dee Murray, she's the founder of the Menopause Experts Group, that really stuck with me. She noted that for years, women with medical contraindications felt completely, quote, left out of the hormone replacement discussion.
It's heartbreakingly true.
But hearing about these new targeted pathways, it feels like the landscape is finally shifting toward genuine inclusion, like they aren't being left behind anymore.
The clinical landscape is fundamentally transforming. We are rapidly moving away from an archaic, binary all-or-nothing approach to menopause care.
Right.
A medical contraindication to an oral pill is no longer the end of the conversation. It triggers a nuanced risk assessment. It prompts collaboration between the patient, a menopause specialist, and perhaps a hematologist or oncologist to basically map out a safe route to symptom relief.
Okay, let's bring all these threads together for you listening. While hormone replacement therapy is remarkably effective for many, it respects strict biological boundaries. Estrogen-sensitive cancers, unexplained uterine bleeding, and active cardiovascular or clotting diseases are hard lines.
Yes, those are the absolute red lights.
But the method of delivery is everything. Swapping an oral pill for a transdermal patch can completely bypass the liver and safely negate blood clot risks. And choosing a local vaginal cream instead of systemic circulation can safely treat debilitating pelvic symptoms without elevating your whole body estrogen. And for those where the hormonal door is locked tight, brain-targeted, non-hormonal therapies like Veoza are finally providing a scientifically sound alternative.
The vital takeaway for you, the listener, is that if you have been told you are entirely out of options, it might be time to ask your doctor about router's administration, local therapies, and the latest non-hormonal receptor antagonists, because the options are expanding rapidly.
They really are. And I want to leave you with a final thought to mull over on your own. Consider how the search for solutions for the people who cannot take a medication is often what drives the greatest leaps in human scientific discovery.
That's interesting.
Think about it. If no one had a contraindication for HRT, if every single person on Earth could just safely take an estrogen pill, we might never have been forced to map the intricate non-hormonal KNDI neuron pathway that controls human body temperature. Sometimes the absolute limits of medicine are exactly what force medicine to evolve.
That is a brilliant perspective. The biological boundary doesn't just protect the patient, it becomes the catalyst for the next great scientific breakthrough.
Exactly. The broken thermostat led us to a completely new understanding of the brain. Well, thanks for joining us on this deep dive. Keep questioning the gold standards, keep advocating for your own biology, and we'll catch you next time.